introduction. And thank you, Sahasra ENT Foundation, for inviting me for this talk. So I'll just start. So audio, video, everything is clear, no?
Yes.
Yes. So I have nothing to disclose, and I have taken informed consent from all the patients shown in the presentation. Now, the learning objective of this today's talk is how to approach the vestibular disorder, like a syndromic approach of vestibular disorders, and I will present the interesting cases. So we know that it's very important to know the tempo of vestibular disorder before approaching. So there are three patterns usually seen in vestibular syndromes. One is acute vestibular syndrome, in which there is sudden onset of this dizziness, which lasts for days to weeks, associated with nausea, vomiting, head motion intolerance. And there are various patterns of recovery, like there could be early recovery, which can be seen in both central and peripheral types of acute unilateral vestibulopathy. And there could be late recovery, which is seen in both types. Especially, I have seen patients with stroke in the posterior circulation, a small, not large volume stroke, especially the cerebellar strokes. They have a tremendous plasticity and it improves faster, similar to the vestibular neuronitis like. But if the brainstem is involved, if the other structures are involved, then the recovery is late and it may not be complete, and the patient might have the vestibular symptoms persistently, and that is uncompensated acute unilateral vestibulopathy. And there could be worsening of symptoms. For example, a patient with suppose vestibular neuronitis develops, he starts recovering, and we see that they develop a different kind of dizziness, which is another vestibular disorder, that is PPPD, which starts happening in the second week or even first week, I have noticed in some patients. So the existing dizziness can worsen, and that can also seen in some central pathologies. So this is the pattern of acute vestibular syndrome. In episodic vestibular syndrome, what happens is dizziness happens. It's a finite duration. It could be less than 1 minute to ranging to hours. And there are two patterns which are seen. That is acute onset episodic and chronic episodic. Acute onset episodic is classically example is BPPV. So in between the two attacks, the patient is relatively normal, doesn't have spinning vertigo. And this is acute onset, and a similar kind of pattern chronically going on, we commonly see in patients with vestibular migraine and Meniere's disease. So that is second pattern. Then the third pattern is chronic vestibular syndrome, in which the dizziness lasts weeks to months or longer. By definition, it should be more than 3 months on a daily basis, most of the days in a month. And so there are various patterns of various diseases in chronic vestibular syndrome. If it is insidious onset, gradually progressive, then it usually goes in favor of neurodegenerative disorders like spinocerebellar ataxias. If it is gradually improving, for example, a patient who has suffered vestibular insult in the past, like acute vestibular syndrome, and it is patient can take more than 3 months to recover. And there is another pattern, that is waxing and waning type of dizziness, which is classically seen in PPPD. So these are the various patterns. So the most important aspect of history taking is whether the attacks are spontaneous versus the attacks are triggered. And the second most important thing is whether it is of acute onset, whether it is episodic in between the two attacks, whether the patient is normal. And the third is whether it is chronic, it is going on a daily basis, most of the days in a month, more than 3 months. So this leads to the formation of 4 syndromes, that is spontaneous episodic vestibular syndrome, triggered episodic vestibular syndrome, acute vestibular syndrome, and chronic vestibular syndrome. So these syndromes, these are the central, common central vestibular disorders, and on this side, these are the common peripheral disorders, and these are the other disorders like functional, psychiatric, and medications. So these are the common causes. For example, most common cause of triggered episodic vestibular syndrome is BPPV. Others are like the other most common cause is vestibular migraine. If you can see, vestibular migraine can present with any of the vestibular syndromes. Perilimb fistula, third window syndromes can also present with triggered episodic. Spontaneous episodic transient ischemic attack, vestibular migraine, Meniere's disease, and vestibular paroxysmia. And acute vestibular syndrome, most commonly due to acute unilateral vestibulopathy and stroke, and it can be because of vestibular migraine, attack of vestibular migraine, demyelination, labyrinthitis. And the most common cause of chronic vestibular syndrome is persistent postural phobic dizziness. There is one more syndrome, the vestibular syndrome, that is falls and drop attacks. So if we remove a little less common ones, these around 7-8 disorder form 80% of the vestibular practice. So if we are thorough in these 7-8 disorders, then 80% of the vestibular disorders we can diagnose and treat properly. So it's very important to be aware of these 7-8 disorders. And the history is very crucial for all these disorders. History forms a major part in the diagnosis. And in the examination, what I do usually is, it's a little, honestly, it is a little like shorter version or shortcut, I can say, but honestly, we should do a thorough examination. But based on history, I decide whether it is a triggered episodic, which syndrome it is. If it is a triggered episodic, positional testing is must. We have to do positional testing. Then if it is a spontaneous episodic vestibular syndrome, history taking is already, we take detailed history, and audiometry in some cases, especially patient, we are suspecting Meniere's disease. And acute vestibular syndrome, hints plus examination is must. For example, a patient comes with triggered episodic, positionally triggered attacks of vertigo. It's not relevant to do a hints plus examination in that patient. But in a patient who has acute onset and continuous vertigo, then it becomes very important, unless the patient has some central symptoms in case of triggered episodic vestibular syndrome. If a patient has positional vertigo with some red flags, then definitely yes. But these are the important things which I'm mentioning, which we must do in this particular syndrome. And in chronic vestibular syndrome, we have to do thorough examination like central nervous system, eye movement, abnormalities, cerebellar system examination. So these are the various parts. If we cone down to some parts of examination, these are the important ones. So if we see, I have heard in one of the talk by Professor Gobel, and so history forms 70 to 80% in the diagnosis. Like it helps in the diagnosis of patients in 70 to 80% of times. Just sitting in the chair, you can diagnose the patient by just taking a thorough history. And once you get up from the chair, you must have one hypothesis in mind, that, okay, this patient is suffering from this syndrome, so I will do this examination first if there is a limited amount of time. But it's very important to do a thorough examination, but we can hone down on those particular aspects. So the next is examination forms around 20 to 25% part of the diagnosis. And investigation add up to around 5 to 10%. These investigations are MRI brain, audiometry, VHATs, and other examination. But I would like to add one more point in this examination part is VNG. So I think that VNG is a extension of clinical examination. We are just examining the eye movements in a very detailed fashion. So it is just like ECG is an extension of cardiac examination. Similarly, VNG is an extension of the vestibular system examination. So the tests which are done routinely in vestibular practice, which are commonly done, I will enumerate them. So most of the patients suffering from vestibular disorder, they undergo X-ray cervical spine. And I don't know why it is done. Many a times patients are suffering from clear-cut BPPV, like positionally attacks of vertigo, acute onset. Then I do cervical spine X-ray. May not, in a young patient, especially if a patient is young, less than 40 years, it may not give information. And I think the X-ray cervical spine should get replaced by video nystagmography, because video is it should be a new X-ray for the vestibular system, like video nystagmography. Then many patients undergo MRI cervical spine. Carotid and vertebral Doppler is done many a times, like in patients with vestibular, and shows stenosis, and then it creates a lot of confusion. So when we form a clinical syndrome diagnosis, syndromic approach, and we come to a particular, we cone down to some diagnosis, differential diagnosis, then we can decide which investigation to do, because every investigation is going to show some abnormality. Patients might have some cervical osteophytes. Patient can have some vertebral, one-sided hypoplastic vertebral artery. Some stenosis is there in elderly patients with diabetes and hypertension. Another thing which happens in patients is MRI brain showing non-specific white matter lesion, hypoplastic vertebral arteries, old lacunar infarcts. Then sometimes if we do VHs, audiometry also can show non-specific abnormalities. And most important thing is when you are suspecting central and you do MRI and MRI comes normal, then it becomes very difficult, like to explain how to explain the symptoms and signs. So vestibular testing is by and large to quantify the vestibular deficits and not to qualify diagnosis. So there is no shortcut to the history taking and examination. So examination and history taking should decide which investigation to do, rather than the investigation guiding us like which diagnosis we have. So this is how, with this little introduction, I will start the cases. So, I'll just start with, these are the 5 syndromes, and today I will try to present a few cases of each syndrome. And as Diwali is coming, I have kept 3 cases reserved. I have prepared 7 cases, but I have kept 3 cases reserved. If we get time, there will be a Diwali bonus of another 3 cases. So case number 1. So a 26 years male, he came with history of tremors in his legs, acute onset, like 3 days history of tremors. He came with imbalance of gait. It was causing very much difficulty in the ambulation. He was not having any other symptoms like rotator vertigo. He was not having, no nausea, vomiting, fever during these 3 days. But there was a significant history, that is history of recent upper respiratory tract infection. That is 10 days ago, he suffered from a severe upper respiratory tract infection, which was not COVID. He was tested for COVID, it was negative. And once that infection resolved, and then he developed these symptoms, these tremors in legs. So what I will do, I'll just show you. So the clinical syndrome here is acute onset symmetric ataxia. And I will show you the videos. So this is how his tremors like. Dr. Sriharsha,
yes,
are you
sir,
able to see? Yeah, you're able to see, no?
Yes, yes.
Yeah. So then once he started walking, you can see the amount of difficulty he's having. He's having so much tremulousness in both the legs. So he was having severe tremors, which was leading to difficulty in the ambulation. Then I'll just show you. Yeah, then I performed his examination, like heel shin testing. Like he has to, on the shin, he's moving his heel. So you can see there is gross ataxia in the limbs, lower limbs, on both the sides. Okay. Then I checked his reflexes. They were exaggerated, like even with a finger tap, the reflex knee jerk was coming. Then I tried to check for clonus. There was no clonus, but the reflexes were 3 plus. Like ankle jerk was also exaggerated. And similar to the finger nose ataxia, I tested this ataxia in the lower limbs. He was not able to do it in a coordinated fashion. So the next one is even while sitting, his at rest also he was having tremors in both the lower limbs. So basically, it was a case of subacute acute cerebellar ataxia, which followed a respiratory illness. So yeah, video oculography. Then I did this VNG, and VNG was showing a lot of saccadic intrusions during the spontaneous gaze testing, like center gaze with fixation. There were a lot of saccadic intrusions. You can see there are some square wave jerk and macro saccadic oscillations, not oscillations, macro square wave jerk and square wave jerks. So then when I did testing in the center gaze without fixation, this is a new phenomenon which I learned, like because of this case, and Dr. Srinivas sir, he like first time I came to know about this entity. So if you can see, there is a slow phase of nystagmus. This is a slow phase of nystagmus, and this is fast phase of nystagmus. Okay, then there is a slow phase. Again, there is a fast phase. But if you see this slow phase, there is one saccadic intrusion which is there, and then the slow phase again continues, and then the nystagmus continues. You can see here it clearly, like there is a slow phase of nystagmus. In between there is a saccadic intrusion, and this is like a square wave jerk, and it comes back to the it remembers the same position, and the slow wave the slow phase of nystagmus continues, and then there is a fast phase. So when there is a without fixation, this patient had left beating nystagmus. This is beating towards the left side because the fast phase is towards the left side, and the patient had additional upbeating component. You can see there is upbeating component of nystagmus also, but in the horizontal nystagmus, there is on the slow phase there are these saccadic intrusions. Okay, so this so there are two things to learn from this patient. That is, even in this patient is a suspected case of a central pathology. And the patient had nystagmus without fixation, like there was no nystagmus with fixation. So central lesions can present with nystagmus without fixation. That is very important point. We see in many patients with migraine, the patients have nystagmus without fixation. And so these were the findings. The center gaze, there was mixed left and upbeating nystagmus and square wave intrusions on slow phase of nystagmus. It is just like a brick sitting on the slow phase. You could see that in the there is a it's like a brick which is sitting on the slow phase of the nystagmus. It is also called as a pulsion, and so it's it's one of the abnormality which is seen in central lesions. So MRI brain of this patient was done, and it showed a demyelinating lesion like in the brachium pontis on the left side. So this lesion was there in the brachium pontis. This is pons, okay, and this is middle cerebellar peduncle, and this is cerebellum. So this is Wormian area, and you can see like hyperintensity which is present in the middle cerebellar peduncle. So it's a case of post-infectious ADEM, acute disseminated encephalomyelitis. No, it is a limited form of demyelination which is present in the cerebellum only. And he underwent CSF examination. IV methylprednisolone was started 1 gram for 3 days, and he had improvement in his ataxia. And after discharge, basically he lost to follow because he had some other issues, and he went back to his native country for the further treatment. But there was improvement in his ataxia. Now coming to the case 2, 29 years lady. She is a known case of multiple sclerosis from 2 years. She was on weekly interferon therapy, but because of this lockdown and some financial issues, she started taking these injections every 10 days instead of weekly. And she presented to me with 1 month history of acute onset imbalance of gait. And she was not having any other symptoms, and this feeling was continuous, like especially while standing and walking, and it was spontaneous in onset. Her higher functions were normal. Cranial nerve examination, she was having pure torsional nystagmus in center gaze, and I couldn't appreciate any other abnormalities which were found during the VNG, like video nystagmography. I'm going to show that. Motor system, the power was normal, deep tendon reflexes were exaggerated, sensory system was normal, and cerebellar signs, she was walking with wide-based ataxic gait, tandem gait was ataxic. She was able to stand with eyes open, but Romberg's was strongly positive. So she underwent a video nystagmography, and it was a very interesting case. I learned a lot from this case. So what is happening is this green one is a stimulus. So the red, this red graph is of the subcard, which is from the right, from the left to the right. So the stimulus is moving from the left to the right. So the eye is moving from the left to the right. Okay, so this is nothing but abduction of right eye, and this is nothing but adduction of left eye, and this is nothing but the adduction of right eye, and this is abduction of the left eye. So what is happening, if you see, is there is an nystagmus. If you can see carefully, this is a fast phase, and there is a slow phase, fast phase, slow phase. So there is a nystagmus in the abducting eye, and you can see the adduction is glycadic, like there is a drift. It is not, it is slowed. It is slow as compared to the fellow eye, the right eye. It's better that I'll show the video, then you will be able to appreciate. I'll show you this case 2. So yeah. So if you keep looking first, one by one we will see. First, look at the right eye abduction. You can see there is an nystagmus, okay? Then look at the left eye adduction as compared to the right eye abduction. If you see, it is glycadic, it is slow as compared to the right eye abduction. The right eye, left eye adduction is slow as compared to the right eye abduction. Now this is nothing but it is going in favor of left-sided internuclear ophthalmoplegia, because the left adduction is not exactly paratic, but it is causing a there is reduced velocity of the subcard, and it is causing a drift, and there is abduction. I think, are you all able to see the video clearly?
Yes, sir. You can actually optimize your screen share for video, then it will be a little more.
Okay, okay, I'll do that.
So you can just once stop your screen share,
Stop sharing. Okay,
then
and
again
then
click share. Uh, can you see? Can you see a
motion
small
and video.
optimize for motion and video? Yeah, yeah. Then it will be better.
Okay, but will my screen get blurred because of this?
No, no, no.
Like routine presentation. You okay? So yeah.
Yeah,
So
yeah.
what? Okay, okay. So if it is getting blurred, let me know. Okay. So what is happening here is there is right eye abduction nystagmus and there is hypometric saccade with the glycemic correction on the left side like. So I have shown this video and then I tried to compare the velocity of this saccade on the adduction saccade and the abduction saccade on the right side. If you can see there is significant difference in the velocity. The right eye is moving it is moving with 227 degrees per second and the left eye is moving at a velocity of 101. So there is significant difference in the velocity on the right and left. Uh, and similar thing was seen in even in this like the on the other side also. So it's debatable whether the patient has bilateral INO, but definitely the patient has left-sided INO. The right one is debatable where there is no abduction nystagmus, but even on this side there is significant reduction in the speed of the saccade on the adduction, right eye adduction. Now coming to the next findings, this patient, this vertical saccadic movements were preserved. It was, but there was upbeating nystagmus on the when the eye moves up. There is upbeating nystagmus, and if you can see this is smooth pursuit, and smooth pursuit, the horizontal smooth pursuit, it is interrupted by multiple intrusions. There are saccadic intrusions in the smooth pursuit, horizontal smooth pursuit, and vertical smooth pursuit was totally impaired. Like it was patient was not able to perform it well, the vertical smooth pursuit. So basically, what happens in internuclear ophthalmoplegia is there is nystagmus of abducting eye, and ideally there should be paresis, but because of VNG, I could pick up the slowness of adduction.
Sorry for interrupting you, sir. Your screen got cropped, sir. I think this is not working. Can you go back to our original setting?
Yeah, I'll go. So I'll stop sharing and share. Okay. Okay.
It's better now.
Yeah. So, uh, then the adduction paresis or slowness happens because of disruption of signals carried by the MLF traveling from abducens nucleus to oculomotor nucleus. And we can use optokinetic drum and check whether this sided adduction, we can check for that. So it was severely impaired. Even optokinetic testing I have done in this patient, the gain was very less for the adduction. Now coming to the other findings of this VNG, uh, but are you at least able to appreciate the videos like for everyone it is blurred or for few like?
No, sir. Actually, there's some lack.
Black.
But
So I will, yeah.
you can appreciate it.
Okay. I will show the the pure torsional nystagmus. I will show. So can you appreciate this pure torsional nystagmus? The upper pole is beating to the right side. If you can see again, I will show. Okay. I think because of network issue, it will be very difficult because it's very subtle nystagmus. So a patient had pure torsional nystagmus. The upper pole was beating to the right side. So these were the findings on the VNG. Like these were the various findings. And MRI brain is still pending. It is not yet done because of financial issues. But I'm treating her as acute relapse of MS because she's a known case of MS and she's on steroids for her acute relapse. Now coming to the case 3, history is 62-year gentleman. He's a known diabetic, hypertensive. He came with history of recurrent spontaneous attacks of vertigo lasting for 2 minutes. And it was associated with imbalance and shaking of vision. He was feeling oscillopsia during the episode, and he was feeling ataxic, like imbalance during that time. And he had one such episode 2 months ago, and when he presented to me, he had one episode on a daily basis for 3 days. His clinical examination was normal. His video oculography, it was also normal. Then I would like to initiate this poll for all. 1 second. Okay, I'll just initiate the poll. 1 minute. Yeah. So the first question is everyone able to see first question of the poll? Dr. Sriharsha?
Yes, sir. Yes.
You're able to see, no?
Yes, yes.
So this patient presented with recurrent attacks of like imbalance lasting for 2 minutes associated with imbalance oscillopsia. So which clinical syndrome we are dealing with? Like is it spontaneous episodic vestibular syndrome, triggered episodic, acute vestibular syndrome, and chronic vestibular syndrome? Okay. So I got a few yeah. Few people have answered it like, yes, it is a spontaneous episodic vestibular syndrome we are dealing with. And so in this patient, so how will you, 1 second. Yeah. How do you approach patients with spontaneous episodic vestibular syndrome? So what are the differential diagnoses in patients? One is transient ischemic attack. Second is vestibular migraine. Third is Meniere's disease. Others are like vestibular paroxysmia. So the duration of attack was 2 minutes, and patient has history of vascular risk factors. That is, he's a diabetic and hypertensive. So in this patient, like because I don't think like not many people what shall we do? Shall we go ahead? Because I think it is I'm not able to put it properly. So I think the probable cause here we are dealing with is mostly transient ischemic attacks because the patient has a history of vascular risk factors and the patient is having oscillopsia and imbalance. Okay, So imaging is indicated or not? Yes, definitely it is indicated. So I did his imaging. So just look at, this is the vertebral artery on the left side. I will show you the findings. Then continuously look at the vertebral artery course. It is, we could see here on the left side, then it is going to the right side, and it is compressing the medulla. Anterolateral surface of medulla, it is compressing, and it is causing displacement also of the medulla on the anterolateral surface. So you can see a large vertebral artery, and it is dolichoectatic, and it is going from the left side towards the to the right side in its course, and it is compressing the anterolateral surface on the right side of the medulla. So the cause of transient ischemic attack in this patient, what it could be? Is it called as rotational vertebral artery syndrome, or subclavian steel, vertebral dissection, or vertebral artery compression syndrome? So I will just I'm not able to initiate individual question poll, so it's okay. We'll leave it. So this condition is called as vertebral artery compression syndrome. We will go into this. I will show you. First, the anatomy of vertebral artery I will show. So basically on the left side, this is subclavian artery, and this is carotid artery, common carotid artery. On the right side, there is brachiocephalic trunk. This is common carotid artery, and this is left this is the right subclavian and right vertebral artery, which is arising from this right brachiocephalic trunk. So this is the first part of subclavian artery from which this vertebral artery originates, and this vertebral artery has 4 parts, that is V1, V2, V3, and V4. The V1 starts from the origin of vertebral artery till the transverse foramen of C6, and the V2 starts from transverse foramen of C6 to C2, and the V3 part of the vertebral artery is from transverse foramen of C2 till it enters to the dura mater, and then the V4, once it enters into the intracranially, then that portion is till it meets the other adjacent vertebral artery, like the counterpart vertebral artery, and form the basilar artery. It is V4 segment. So there are various vertebral artery pathologies which can be which we know. One is the subclavian steel, in which the first part of subclavian artery before the origin of vertebral artery, there is stenosis of this subclavian artery proximal to the origin of vertebral artery. So suppose there is a stenosis here, what will happen is the left arm supply is done by this artery. There is retrograde flow of the blood in the left subclavian artery from the contralateral vertebral artery. It will go through the here in the basilar, and there will be retrograde flow in the left subclavian artery, and it will supply the left arm. This gets compensated until the patient does left arm exercise. What will happen is the more amount of blood gets stealed from the contralateral vertebral artery, and that leads to subclavian steal syndrome. That is, patient will present with vertebrobasilar insufficiency, and that is transient ischemic attacks happening because of this stenosis. Okay, so this is subclavian steal. Vertebral artery dissection happens mainly in young patients because of sudden neck jerks. There can be intimal tear of the vertebral artery. Then the rotational vertebral artery syndrome is nothing but hypoplastic vertebral on one side, and the other side there is a dominant vertebral artery in these patients. And hypoplastic is nothing but if there is diameter is less than 2 millimeters at V4 segment, and dominant vertebral artery is nothing but more than 0.3 millimeter difference in vertebral artery. The one usually there is one vertebral artery which is dominant, but other side may be hypoplastic or may not be hypoplastic depending on the diameter at V4. So in these patients with hypoplastic or dominant vertebral artery, when the patient turns the neck to the other to the hypoplastic side, what happens is the dominant vertebral artery gets compressed, and that leads to vertebrobasilar insufficiency, that is rotational vertebral artery syndrome. And this is a new syndrome which is in October 2019. An article came by Professor Louis Kaplan, who is like authority in stroke syndromes. So this syndrome is called as vertebral artery compression syndrome. And one more thing is about this vertebrobasilar system is vertebrobasilar dolichoectasia. When can we call basilar artery as dolichoectatic? It is if it is more than 4.5 millimeters at midpons, the diameter. So this vertebral artery compression syndrome is like it was first described in 2006 by Louis Kaplan, and it was later named in October 2019 as vertebral artery compression syndrome, and it leads to transient ischemic attacks because of compression of medulla, and this pulsatile impact of a tortuous vertebral artery on brainstem leads to blood flow insufficiency in perforating branches, and that leads to the transient ischemic attacks. And the treatment for this condition is like the other transient ischemic attack. Most of the times it is a conservative treatment, but if it is large dolichoectasia, it needs like decompression. But I started the patient on clopidogrel, and the patient had a very good recovery of his symptom. There were no further episodes after starting the antiplatelets and statins. So this, because of this particular patient, I then went into my old records and I could correlate that I missed 2 patients in the past, like both had this compression of medulla. You can see the anterolateral aspect of medulla is getting compressed by the vertebral artery here. And here on the left side, it is getting compressed, here on the right side. So I missed 2 patients in the past, and I could diagnose 2 more patients after reading this article. So it's a continuous learning process. We keep learning, and it's very important to have a good neuroradiology backup. And the radiologist specifically wrote about in the reporting, he wrote about this particular finding that made me to think of this particular syndrome. So you can see the compression of the medulla by the vertebral artery. So take home message from this is think of transient ischemic attack if vascular risk factors are present. There are associated neurological symptoms and signs, and positional testing is negative. If you are thinking in terms of like PPPD and the positional testing is negative, we can go for imaging and check for TIs. Now coming to the case 4, this patient, young male, patient presented with recurrent episodes of headache from 1 year. Frequency was 1 or 2 episodes per month. The attacks were stereotypical. Every attack was similar to it was similar. Every time it was similar tempo. Like first he gets spinning vertigo lasting for minutes, around 15 to 20 minutes. Then it was followed by hemicranial throbbing headache, sometimes right, sometimes left. Then it was followed by drowsiness and imbalance of gait, but headache continues during this time. And he feels drowsy, he can't walk, and he can't move during the attack. He has to take rest. He feels better after a period of rest. So after sleeping for 2 to 4 hours, he feels better in after this attack. So the triggers for these attacks were exposure to sun, strong smell, change in sleep pattern, and certain foodstuffs. So these attacks were typically triggered by triggers which we regularly see in case of migraine.
Hello, sorry for my intervention, because I wanted to ask a question, if I may, with regards to the previous exam.
Yes, yeah, you can. Yeah. Yes, please.
My question is, with regards to the cause of the patient's symptoms, then why are the episodes episodic and spontaneous?
In case of so this is something similar to this compression is something similar to the vestibular paroxysmia. In patients with vestibular paroxysmia, we don't see symptoms all the time. It gets triggered sometimes. Similarly, in patients with trigeminal neuralgia, even though there is a neurovascular compression on the nerve, trigeminal nerve, the patients don't develop symptom all the time. Although there is little contact, but I honestly I don't know why it becomes spontaneous and it is not continuous like it should be continuous. But initially there is compression of these small vessels because of this large dolichoectatic artery. It is compressing and maybe the collateral circulation is helping other times, but the collateral circulation is not sufficient and it is leading to symptoms. That's what I feel, because this is a relatively new syndrome. Maybe I'll read about it maybe next time I can answer better.
Oh, thank you very much. Thank you.
Coming back to this case, interrectal neurological examination was normal. And so I would like to know, what is the diagnosis in this patient who presented with stereotypical attacks, this patient was getting spinning vertigo followed by headache, hemicranial headache associated with drowsiness and imbalance. So I'm not able to do the poll. So what I will do is, the differential diagnosis which I considered was, it was first three especially, like vestibular migraine with brainstem aura, whether it was a transient ischemic attacks, and yes, complex partial seizures, patient was feeling drowsy. It can be considered as a differential diagnosis. So now I will come to the differences between vestibular migraine and the migraine with brainstem aura, which was earlier known as basilar migraine. So what happens, coming to the diagnostic criteria of migraine with brainstem aura, the patient will fulfill the criteria for migraine with aura and aura with both of the following. At least two of the following fully reversible brainstem symptoms, that is dysarthria, vertigo, tinnitus, hypacusis, diplopia, ataxia, and decreased level of consciousness. So in this patient had vertigo, this patient had ataxia, and this patient had decreased level of consciousness. So there were three reversible brainstem symptoms, and there was no motor or retinal symptom. So if we look at the migraine, there are four phases in the migraine. There is a prodrome, there is aura phase, there is attack, and there is a postdrome. So these are the four phases of migraine. Suppose the patient gets any of the aura symptoms before the headache, like visual, patient gets visual aura. This is migraine with visual aura. Patient has sensory symptom, migraine with sensory aura. So depending on which type of aura symptom patient gets, then it is classified whether the patient has migraine with brainstem aura. So the various symptoms which are considered are these brainstem symptoms, like dysarthria, vertigo, which is seen in 60% patients, tinnitus, hypacusis, diplopia, ataxia, and decreased level of consciousness. So two of these symptoms must be present to qualify it as migraine with brainstem aura. And to differentiate it from migraine, vestibular migraine, in vestibular migraine patients, the headache and vertigo, the vertigo can happen during the attack of headache, before the attacks of headache, and even interictally also. So it can happen in any phase. It doesn't specifically happen only before the headache. Although there is a small fraction of patients with vestibular migraine who can get this vertigo, specifically some attacks they can get before the headache. But other episodes they might be having without headache, and it might be falling. during headache also. But in case of migraine with brainstem aura, it will specifically happen before the headache. So these are the differences. Like in migraine with brainstem aura, there are stereotypical attacks, vertigo in 60% patient, not every patient. Brainstem symptoms other than vertigo also occur, and aura phase, it specifically happens during the aura phase. And one more point I learned, because I shared this case and I learned this point, that is there is a suggestion, that is grade 2C evidence, not using beta blockers and triptans or ergotamine derivatives, because of theoretical concerns and anecdotal evidence that these medications may lead to cerebral ischemia. Although this patient received beta blocker for a week, he was all right. Then I called him back and I gave him topiramate. When I came to know about this, I started him on topiramate, and he's doing fine on topiramate. And ideally, the drug of choice they have mentioned is verapamil. Topiramate can also be given, and lamotrigine is also another drug which can be started in these patients. Coming to the case 5, 37-year gentleman, known diabetic, hypertensive, hyperlipidemia. He presented with 3 episodes of vertigo. First episode was 27 days ago. It lasted for 6 hours, and the patient had acute onset, spontaneous. It was not triggered. It was continuous vertigo for 6 hours continuously, and with episodes of vomiting. And it was not associated with tinnitus, hearing loss, central symptoms. And he was hospitalized, and he underwent the MRI. And obviously, the first diagnosis which comes in mind in monosymptomatic vertigo in a diabetic, hypertensive, hyperlipidemic is a transient ischemic attack. And he was started on antiplatelet statins, and he was discharged. Then he had second episode, another episode which lasted for 8 hours. Patient had acute onset, spontaneous, continuous, again similar presentation with vomiting. He denied. In this time also there was no tinnitus, hearing loss, central symptoms. And he was hospitalized. MRI brain with contrast was done, and he was discharged with a diagnosis of BPPD with beta histine and synarizine. Then the third episode happened 6 days before he met me, which lasted for 12 hours. Patient had acute onset, spontaneous, continuous vertigo. There was no hearing loss, central symptoms. There were no central symptoms. But patient noticed bilateral mild continuous tinnitus, he noticed from few days. And he also noticed mild non-throbbing holocranial headaches without any photophobia and phonophobia. And the patient was referred to me, and then I did this imaging. Like I saw all the imaging done, which was done in the past. The second episode, he underwent MRI brain with contrast, that I saw, and I had a wrong impression about the findings, which like I will show you. At that time, I was under impression that this one. Yes, at this point you can see, yeah. I felt that it is a case of this MRI showing this endolymphatic hydrops here, which I felt so, but I was completely wrong. I took opinion from Dr. Manoj Agarwal. He's a senior ENT surgeon, and he's very good in radiology. Then I discussed with 2 of our radiologists. I discussed with Dr. Srinivas sir, and all of them were of the opinion that this is not endolymphatic hydrops. And and even the audiogram also I did, which was normal, completely normal. So I have this question to the audience, that is whether it's a case of vestibular migraine or it's a Meniere's disease. It's a very difficult question, because the natural history, currently he's getting only monosymptomatic vertigo. He's not having tinnitus and hearing loss, but in future he needs follow-up. But currently I started him treatment as case of after the third attack. When he consulted me, I started him on migraine prophylaxis, and I started him on this. I told him strictly all the lifestyle modification for the migraine. He was having a disturbed lifestyle. He was working on the screen for a long time. And after starting him on beta blocker, there were no further attacks in 2 months of follow-up till date. 2 months, he didn't get any further attack, but he needs follow-up for the diagnosis. Why? Because I'm going to, after a few days, like last 15 days ago, he came up with his cousin brother. And his cousin brother is 67-year gentleman. He's again diabetic, hypertensive, but he has typical Meniere's disease. Like he has multiple attacks of vertigo, tinnitus, hearing loss, and the audiogram is showing mixed sensory loss, and clinical examination is also showing right-sided sensory neural hearing loss. So this cousin, he told me one interesting thing about his attacks. He told me that 2 of his attacks came next day after the hair dye. This is the first time like I came to know. Then I went into literature and found that there is a lot of relation with the chemicals. That is, for example, drugs taken orally by mouth, by injection, hair color, that hair dye can trigger an attack of Meniere's, inhalant sprays, acne or skin care preparations, dental procedures, and adjusted bottled water or eye drops. These are other chemical applications which can trigger Meniere's disease that I came to know. Maybe it is triggering the underlying pathogenesis similar to migraine and triggering the attack, but I'm not sure about this. But this was something interesting which I found I would share. Then I went to, because he came with the cousin brother, this is the first patient whom I'm treating as vestibular migraine. And this is his cousin brother who is typical Meniere's disease. Then I just went into his family history. Then I found that his father, father of the first patient, is also suffering from something similar to Meniere's disease. He has unilateral hearing loss, vertigo, tinnitus. The patient's sister is also suffering from similar issue. Then the cousin brother's father, the first patient's uncle, is also suffering from similar complaints, and the grandmother also had similar symptoms. And he has 3 sisters. Out of them, 2 sisters are affected with he has 4 sisters. Out of them, 3 are affected with Meniere's disease, and 1 is she is normal, she has normal hearing and balance. And on the maternal side of the cousin brother's mother, grandmother, she has, I took history, it was appearing like Meniere's disease. So in one family, I saw this clustering of cases, and but this person may develop Meniere's disease later, I don't know. But currently, I'm treating him as vestibular migraine, and this patient is typical Meniere's disease. His age is 61, his age is 37. So there was no consanguinity. Both male or female are affected, and female are affected. Every generation is affected. So it looks like an autosomal dominant inheritance of this particular problem. And then I read one article about genetics of Meniere's disease, but the conclusion of article is there is no convincing evidence for an association with specific gene. One specific gene is not yet found which is related to Meniere's disease. There is a lot of genetic heterogeneity, and there is a lot of phenotypic diversity of Meniere's disease. That is very important. In the same family, this cousin brother is having different types of attack, like currently he has monosymptomatic vertigo, and this other patient is having typical Meniere's disease. It's a complex disease, as we all of us know, and so they concluded that it could be combined effect of environmental factors on a susceptible genetic background. If a patient has susceptibility, genetic susceptibility, and the environmental factors or lifestyle factors are adverse, then it can lead to the attacks. Then the one more interesting finding about Meniere's disease, recently I did, this is another patient of Meniere's disease, in which I did MRI to rule out any other pathology. So the radiologist aptly reported about this, like on the left side, if you compare the vestibular system, vestibule on the right side versus the left side, you will find that the left-sided vestibule is hypoplastic. And this patient has had 3 or 4 attacks of this Meniere's on the left side, and his hearing is totally lost in this year, and he has baseline imbalance like unilateral vestibulopathy. This finding, I'm so lucky that the radiologist wrote about this particular thing, and I came to know that it can happen in Meniere's, that is vestibular, because of recurrent attack, there is hypoplasia of vestibular system. Now coming to the case 6, the 45 years lady, she came with dizziness on and off from 3 years. Just a minute. So she came with a history of dizziness on and off from 3 years, non-spinning. It was in the form of non-spinning vertigo, unsteadiness, and heaviness of head. The symptoms were waxing and waning. There were fluctuating symptoms. And she, once she wakes up in the morning, she feels fresh. And as the day progresses, her dizziness worsens. She doesn't go out of the house due to the dizziness because of fear of fall. She has tremendous fear about crowded places, like she has severe agoraphobia, and she has fear of complex lights. So this is the graph. Actually, this was plotted by one of my another patient of similar entity, similar illness, in which he had this baseline dizziness. It was there all the time, which was better in the morning. In the morning time, when he wakes up like 6:30 to 7:30, he feels very good, like he's better. But as the day progresses, as he takes bath and has his breakfast, he starts checking his balance, then he feels dizzy, and it is present more in the malls and grocery. It worsens, and on the top of that, he has a lot of flares, momentary flares of dizziness, and it is in the form of unsteadiness and non-spinning vertigo. This patient consulted several physicians, and she was even hospitalized for the same reason. She did several investigations, all were normal, and she underwent MRI cervical spine twice, MRI brain, and everything was normal. And so, one second, there was one video about her examination. Just a minute. Okay, it's missing. Okay. No problem. So the video just showed that her examination was completely normal. She was able to stand on one leg. Her Romberg sign was negative, and she was able to stand on one leg after eye closure for more than 5 seconds. So if a patient is able to stand for more than 5 seconds on one leg with eyes closed, then essentially the vestibular system or the balance control is normal. Not only vestibular, the proprioceptive and like the balance, cerebellum, everything is normal. So in this patient, so what's the diagnosis? Like paraneoplastic, vestibular migraine, persistent postural perceptual dizziness, and bilateral vestibulopathy. So in this patient, as the examination was normal, patient was having dizziness, long-standing dizziness. It was in the form of non-spinning vertigo and unsteadiness. It was getting aggravated in upright posture. It was getting aggravated by complex lights, and she had agoraphobia. So I consider the diagnosis of triple PD, persistent postural perceptual dizziness, which has 3 components. One is visual component, second is postural component, and third is movement, like motion component. And I have started using this NIGATA triple PD questionnaire from last 2 months, and I found it is very useful in patients with triple PD and even other disorders which I'm going to mention. Like there are 4 questions which are related to the visual score. There are 4 questions which are related to the upright posture. And there are 4 questions which are related to the movement. When the patient is in action movement, then whether the patient feels dizzy. And this is a scale from 0 to 6, and the total score is ranges from 0 to 72. And what are my findings in last 2 months, I will show you. Oh, this is okay, this is the video of that patient, like modified Romberg's test I have done. Like patient was able to stand for more than 5 seconds. Okay, she could stand for 9 seconds. And on the left leg, also she was able to stand for more than 5 seconds. So if a patient is able to stand with the eyes closed, you can, essentially the system balance control is normal. And you can see even the cervical collar here. So many of these patients with triple PD, vestibular migraine, PPPD, unfortunately, they get a diagnosis of cervical dizziness, cervical vertigo, and they are put on recurrent physiotherapy and cervical collar. I don't deny like this, the diagnosis sometimes we can see a patient with, but first we need to rule out an organic vestibular disorder before coming to conclusion that it could be because of cervical proprioception. So it's very important, cervical proprioception or the cervicocolic reflex. So it's very important to consider the genuine vestibular disorder first before labeling the patient as a case of, I think it is a diagnosis of exclusion rather than diagnosis of like we should consider first. So it's very important to rule out genuine vestibular disorders first than coming to a little debatable diagnosis. So this is the diagnostic criteria of persistent perceptual postural dizziness. That is the symptoms lasting 3 months or more. They are persistent, but they are fluctuating. As the day progresses, they increase, and there are momentary flares. And the exposure to visual stimuli increases, it can develop slowly, insidious onset. It could be gradually progressive also. That pattern is also seen. And it causes significant distress and functional impairment, and it cannot be attributed to other disorder. So treatment is SSRIs, SNRIs, like selective serotonin reuptake inhibitors or selective norepinephrine, serotonin or norepinephrine reuptake inhibitor, or tricyclic antidepressants. Usually I prefer to start with amitriptyline. I found that in 80% of patients, I have around 100 cases of triple PD, and 80% of them show very good improvement with tricyclic antidepressant, that is amitriptyline. But the improvement is not 100% with medication alone. Like patients improve around 60 to 70%, or some patients, if I'm lucky, like it goes to up to 90% in some patient. But drugs doesn't cause 100% improvement. And the other drugs which I use, if patient is not able to tolerate tricyclic antidepressant, I go for SNRI, that is venlafaxine and desvenlafaxine. These are also very good drugs for patients who cannot tolerate tricyclic antidepressant. And it's very important to address the psychological issues. Vestibular rehabilitation is important. And one more thing I would like to mention is I do give beta blockers in these patients, and it works very well. Beta blockers like bisoprolol, Inderol, it works, and even magnesium works very good in these patients. So some patients who are not having very good relief with these drugs, I add beta blockers and magnesium, and I found very good results with one of my patients is only on magnesium. He feels, when I added it, then he started feeling very good improvement in the dizziness, and he's only on magnesium monotherapy. That is only one patient, but it needs to be studied and evaluated. So these are the 3 components of this triple PD questionnaire. And what I see is visual score is very important for the diagnosis of triple PD. If visual score is 0, you need to consider other diagnosis like proprioceptive loss or other issues. And upright posture, if the symptoms are happening in upright posture and visual score is 0, then look for the proprioceptive loss or cerebellar issues. And movement, when the movement score is also very important. Some patients have exclusively this problem only while riding a car. That is one form of triple PD, that is motorist vestibular disorientation syndrome. So every vestibular disorder can have a positive score, but pattern recognition is important. So I will just mention about the pattern recognition which I have seen in last 2 months in patients. In triple PD, as I have mentioned, all the score, all the points are there. Patients score in all the questions, most of the questions, but especially the visual score is very important. It has to be it should be positive. Like if patient doesn't have any visual symptoms, then it is less likely that it is a triple PD. Then comes the visual vertigo. In visual vertigo, exclusively the patient will have a visual score. The patient will not have any score on upright posture or movement. That is about the visual vertigo. I'm just trying to create an effect of visual vertigo with my animation. So in the vestibular migraine specifically, I have seen most of the patient, when I do the scoring in this vestibular migraine patient, one question definitely they will say yes is watching a scroll screen on a PC or smartphone makes them feel dizzy. Is a very important marker, I feel. It is a very important thing which is seen in patients with vestibular migraine. And even patients with vestibular migraine, they tell that there is a difficulty in focusing and concentrating at the screen. It's a very common symptom, I feel, in patients with vestibular migraine. So there is a lot of overlap between triple PD, vestibular migraine, visual vertigo. But we can recognize the pattern and then we can decide which disorder the patient is suffering from. Then they're coming to task-specific problem. If there are some patients who have only dizziness while driving a car. As a driver, if a person is driving the car and feels dizzy, then it is motorist vestibular disorientation syndrome. And if a person is like a passenger and develops dizziness specifically in the car, in the motion, patient, mostly these are cases of motion sickness, either primary or secondary because of some underlying vestibular disorder. Then I'll go to the 1 second. Yes. Difference between triple PD and bilateral vestibulopathy, there is no oscillopsia in triple PD, but oscillopsia is seen in 30 to 40% patients with bilateral vestibulopathy. Abnormal examination in bilateral vestibulopathy, that is abnormal head impulse test, caloric testing, positive Romberg sign, minimal symptoms. This is very important thing which helps to differentiate bilateral vestibulopathy from triple PD is when they are still, then when they are not moving their head, patients will feel minimal symptoms. They don't have much symptoms. But in triple PD, if a patient is sitting, even sitting in upright posture and not using the back support and arm support, then also patients can feel dizzy. That is one point to differentiate. And so whenever we get challenged by a patient who presents with unsteadiness of gait, we must check for vestibular abnormalities, symptoms and abnormalities and signs, and proprioceptive symptoms and signs. So what are these symptoms and signs? Symptoms of proprioceptive loss are tingling numbness, cotton wool sensation, band-like sensation, Hermit's phenomenon. Slipping of chappals from feet without knowledge is proprioceptive loss. I'm really sorry for my spelling mistakes because I was literally falling short of time. And in patients with proprioceptive loss, patients will have absent or exaggerated reflexes. If the reflexes are absent, then proprioceptive loss is due to neuropathy. If reflexes are exaggerated, the proprioceptive loss is due to myelopathy. Then then the patient will have loss of sense of position, vibratory sensation. I check in every patient of like who presents with tingling numbness in the feet, or patients have imbalance. It's very important to check vibratory sensation in the great toe versus at the ankle and versus higher up. If there is a graded loss, it goes in favor of neuropathy. And positive rhombus can be seen in proprioceptive loss also and vestibular loss also. So it's very important to look at the symptoms and other signs. A nerve conduction study can be performed to check, but again I will tell, if we do nerve conduction study without having any hypothesis or in mind, what happens, it might show some abnormalities and we might correlate it. Similar thing can happen with VHITs also. So patients with vestibular loss have 30 to 40% cases have oscillopsia, abnormal examination, and VHITs is a very important study to check for the vestibular loss. And one case I have seen when I was 8 years ago, when just I started practice, I saw one case where the patient had retinitis pigmentosa, and she presented with gradually difficulty while walking. So that was one interesting thing I thought of sharing. One last case, very short case, only three slides. This 67-year gentleman, non-diabetic, hypertensive, imbalance of gait with swaying sideways and forwards. It's on a daily basis from 1 year. It was mild to begin with, and it has worsened from last 1 month. He has issues while standing and walking, and he does not have any issue when sitting with back and arm support. And he cannot turn his head while walking. That was very important history he told. And he feels worse when standing at one place, and walking barefoot. He feels like he is walking on a rubber. But he had history of bilateral tinnitus from 5 years. So I had a confusion in my mind. There are some findings, some symptoms which are in favor of proprioceptive loss, and there are some symptoms which are favoring the audiovestibular loss. Even he was complaining of little hearing loss. So I did his triple PD score. The postural score was 7, the motion score was 3, and visual score was 0. So the visual score was 0. Practically, it might come in future, but I'm just telling my experience that a triple PD visual score is very important. Like visual score, they will score some points. There is one article published recently which says that visual score of 9 out of 24 is very specific for the diagnosis for the triple PD. Then on examination, he had absent knee jerk, ankle jerk, loss of hairs on both the legs. That is very important sign of peripheral neuropathy. He had graded vibratory loss in feet, and Romberg sign was positive. And his VNG was absolutely normal, video nystagmography. VHITs it was normal. His vitamin B12 and TSH is normal. And in nerve conduction study, he had severe axonal sensorimotor neuropathy. So when we have hypothesis in mind and then we do the testing, then we can cone down our diagnosis, and his visual score was 0. So the difference between triple PD and peripheral neuropathy is, I discussed all these symptoms of patients with peripheral neuropathy. And even we can consider, instead of triple PD, we can say vestibular loss. Patients will, if we want to differentiate it from proprioceptive loss, these are the symptoms and these are the signs. And there are no visual symptoms that goes against diagnosis of peripheral neuropathy. So it could be associated also. Patient might have underlying peripheral neuropathy and have a dual disorder, might have triple PD associated with it. So there was recently one question, that is, what is difference between positional and positioning? Positional means a patient, suppose, is lying down or in one position, in sitting position, standing, walking, or running. So if a person is complaining that he has dizziness only while standing and walking in upright posture, like all these four, and gets relieved by supine position, that is characteristic of triple PD. Patients will have dizziness only in upright posture, sitting without back and arm support, standing, walking, running, they will have difficulty, but lying down they feel better. That is very characteristic in triple PD. But in bilateral vestibulopathy, the sitting they will be with head stable, they will be comfortable. If they sit and keep their head stable, they will feel okay, and they will feel symptoms in standing, walking, and running, and even other disorders like, for example, Parkinson's, ataxia, cerebellar ataxia. The symptoms are present only when patient is standing, walking, as compared to the sitting and lying down. So these are some things. And positioning means if a person changes the position and then the dizziness appears, then that is called as, I think it is not working, but if a person from supine position sits up, or from sitting position patient lies down and then they develop vertigo or dizziness, then it is called as positioning. So positioning dizziness or vertigo. So this is about the cases. Thank you so much, Sriharsha, for giving me this opportunity, and I'm happy to answer the questions.
So thank you, sir. So we have questions. Yeah, we will open up the question and answer session for the audience now. So one question was, does vascular loop contribute to characteristics of Meniere's disease or vertigo, tinnitus, or hearing loss?
See, vascular loops, if they are compressing the vestibular nerve and vestibulocochlear nerve in the transitional zone, then and it is causing indentation, angulation, then it can lead to vertigo, which is classically less than 1 minute. Usually it is lasting for a few seconds, 1 or 2 seconds. That is vestibular paroxysmia. Yes, patients can present with episodic tinnitus in patients with vascular compression. So vertigo and tinnitus can happen in patients with that is paroxysmal, like less than 1 minute duration. And if the later on, when the compression is chronic and patients can develop a constant dizziness, like because of vestibulopathy. So I hope I answered the question.
Yes. So yeah, we are the unmute option has been enabled. You can directly unmute and interact with the speaker.
Hello, sir.
Yeah, hi.
Sir, in the last case, like you said, that you went for B12 estimation and TSH. But in the first case, like you said, there was history of URTI. So why
Yes.
didn't you suspect that maybe he was given some antibiotic which caused vitamin B12 deficiency, which could have been the reason of vertigo?
Yeah, honestly, I didn't mention about the B12 and TSH in that case, but it was done and it was normal. And you are right, it can present like B12, but very acute onset, like 3 days history with MRI showing that lesion, and it is less likely. But I checked B12 and TSH in that case also, and it was normal.
Thank you, sir.
There's one question from the audience. In most cases of hydrops, Meniere's, BPPV, the most affected canal is lateral canal. Any reason why the lateral canal is affected?
Okay. In cases of hydrops.
Yes.
Which cases the lateral canal is commonly affected? Hydrops.
Actual question, I think, should be reframed probably.
Here, can I see the questions? I can see directly, maybe.
Hello.
And, yeah. Hi, ma'am.
Hello, hello. Good evening. Sir, in mostly Meniere's cases, BPPV, we can see in lateral canal. Why lateral canal is only mainly affected?
I have not come across. I have seen one patient with Meniere's disease who had actually he had a posterior canal BPPV, but I have not come across any literature saying that lateral canal is affected. But I have like in cases of vestibular neuritis, patients later on, suppose a patient has superior vestibular neuritis, and patients the posterior canal gets involved because the superior posterior canal is intact, and the superior vestibular nerve supplies the anterior canal and the lateral canal. So in patients with superior vestibular neuritis, the posterior canal BPPV is very common, that I know, but I'm not aware whether lateral canal BPPV is common with hydrops. I'm not sure about that. But only thing I can tell is there is one hypothesis which says that the both have same pathogenesis, like the hydrops, saccular otoconia causing endolymphatic hydrops, blockage of the duct causing hydrops, and the utricular otoconia is leading to the canalithiasis, like BPPV. So that I know, but I'm not sure about why lateral canal is common.
Okay, sir. Thank you.
Dear Vishal, can I pose a question?
Yes, yeah.
First of all, I would like to thank you for the great presentation, and your comments are really helpful. Regarding your first case about vertebral or basilar dolichoectasia, and please tell me your experience. We saw that you found a couple of patients more. So what was the main presenting symptom of their vertigo attacks, please?
All these patients, like I found these patients, one of the patient presented with acute onset vertigo, imbalance of gait, and she lost consciousness, and it lasted for 15-20 minutes. They rushed to the emergency. 15 minutes later she regained her consciousness, and then the imaging was done. And I would like to mention one more thing which I didn't mention, is even the normal caliber vertebral artery, it's not essential that only the vertebro-basilar ectatic artery only will lead to this syndrome. Even a normal caliber artery, if it is in juxtaposition with the medulla, that can also lead to the compression of the medulla. That is one point. And the second, all these patients presented like transient ischemic attacks in the posterior circulation. All these patients, all the 4 patients, which 2 I have missed in the past, and 1 which I diagnosed, and later on I could diagnose another 2, maybe total 5. All of them presented with symptoms of transient ischemic attacks in the posterior circulation.
Lasting for how long? 10 to
Lasting
15
for less than 1 hour, usually 15 minutes. 15 exactly. I don't remember, but they were lasting for less than 1 hour. Not developing infarct. They presented with only transient ischemic attacks.
Thank you very much. Thank you.
Sir, can you suggest a simple way to differentiate central and peripheral vertigo?
This is a very commonly asked question, but sorry, I'm going to disappoint you, because honestly, I'll tell you, there is no shortcut to a detailed history taking and examination. We have to take a detailed history and go do the examination. But if you ask me what are the indicators, like red flags, for example, if you see in the history, if a patient has central symptom like dysarthria, deadly dysarthria, dysphagia, diplopia, brainstem symptoms, sensory symptoms, motor symptoms, then we should consider definitely a central cause. Patients with high ABCD2 score, like age, like these are all vascular risk factors. If the vascular risk factors are present, think of central. Then this is based on the history, like central symptoms and the high ABCD square score. Then coming to the signs, if you see a central variety of nystagmus, that is pure variety of nystagmus, head thrust is negative in acute vestibular syndrome. So see, all depends on which syndrome you are dealing with. Like in every syndrome, the central and versus peripheral differentiation is different. For example, if a patient presents with triggered episodic vestibular syndrome, like positional vertigo, and if you want to differentiate central and peripheral, the differentiating points are different as compared to a patient presenting with acute vestibular syndrome uh, with central versus peripheral in acute vestibular syndrome. So in acute vestibular syndrome, you have to look at the HINTS plus, that is head impulse test. That is a very short version of how we can differentiate central from peripheral. That is, do a head impulse test in acute vestibular syndrome, positive, usually peripheral, say, normal, it is central. Then if the nystagmus is bidirectional, like gaze evoke, then central. If it is unidirectional, peripheral. And the test for skew deviation, right? If the skew is present, then it is central. Absent, it is peripheral. So it's very important to correlate clinically, identify the syndrome first, and then decide what are the central findings seen in this particular syndrome. For example, the central positioning nystagmus versus peripheral positioning nystagmus, the difference table is different as compared to the spontaneous nystagmus, which is of central or peripheral variety. So it's very important to assess every patient like clinically. Like in chronic vestibular syndrome, again, the differentiation is different, central versus peripheral. So it's not like a few things which can easily differentiate. It's very important to identify syndrome and do the focused examination. Yeah.
Sir, in the
Yeah.
last case of PPPD,
Yeah.
you said that patient was having agoraphobia also, and he was giving history of aggravation of the symptoms during during such encounters. So don't you think that we should also think in the direction of panic disorder sometimes?
Yes. See what happened when this agoraphobia. It was first described in it was first described in Germany, and they that time the professor, I don't exactly remember the name, but it was described in many patients who went to see that particular one, that market area where it was open place and crowded place, and many people, Westphal, actually Professor Westphal. So it was named as Westphal's agoraphobia in 19th century when it was first described. And later on, they found that it was initially it was debate. There was debate going on whether it is a psychiatric condition versus it's a organic neurologic condition. It was an even debate that time, like in 19th century, whether it is a psychiatric or neurologic. And there was not much literature on the functional disorders. And functional disorders are by and large, even today in 21st century, are considered as psychiatric. Many a times these patients who have functional disorders, it is something in between organic and the psychiatric disorder. Many of the patients with functional disorders do have psychiatric comorbidity. That doesn't mean that every patient with functional disorder, not only neurologic, unfortunately, all the patients with functional disorder, they are considered to have, they are pretending the symptoms, they are uh, they have panic disorder or they have anxiety, they have some depression. If you go into the, for example, I have around 100 cases of triple PD. Even I used to think that, okay, you must be having some psychological issues. Do you have stress? Do you have mood disorder? Many patients are absolutely normal. They just had one vestibular disorder. or any other medical disorder which triggered this triple PD. The functional connections got disturbed, and it led to this functional disorder. So agoraphobia it was considered, if you go through the ICD classification of agoraphobia with panic disorder and agoraphobia without panic disorder. There are ICD separate codes for agoraphobia with panic disorder, without panic disorder, and panic disorder it's alone. So it's not that always the agoraphobia is associated with panic disorder.
Thank you, sir.
So there was one question. A 65-year-old female presented with giddiness. She's a known diabetic with on regular medication. MRI brain showed cerebral atrophy, no nystagmus, no relation, no positional changes. That's normal. So, what is your probable diagnosis?
I would like to ask two questions. What was the duration of the vertigo, and what were the associated symptoms, and was it spontaneous or triggered? These three questions will help us to hone down to the syndrome. So maybe the one who has asked, maybe you can unmute your mic. But in the question, chat, what is written? How is the presentation?
Sudden onset.
Sudden onset. Okay, it is acute onset. Okay, so acute. But what is the duration of the attack? Like it is lasting for how much time? Like it is a continuous, or that is very important, because whether it is acute vestibular syndrome versus it is episodic vestibular syndrome, it is important to see. So the one who has asked the question, can you unmute and let us know?
Continuous.
Continuous, okay. Okay, so continuous, if it is continuous, then it is definitely acute vestibular syndrome. Then we have to, even though the patient is diabetic or elderly, that doesn't mean it is going to be central. So then the hints plus examination must be carried out in this patient. What are the results of hints plus, like head impulse test? How is the test of skew, and how is the nystagmus? So no nystagmus. Head impulse testing, was it done? And whether the examination of nystagmus, was it done without fixation? That is also important, because most of the times these disorders, like the peripheral disorders like vestibular neuronitis, is missed only because the examination is not carried out without fixation. So we have to approach it one by one, like we have honed down to acute vestibular syndrome. Now the question is whether it is central or peripheral. MRI brain normal doesn't rule out central etiology. MRI brain abnormal doesn't mean that is the cause of the dizziness. So it's very important to first look clinically into it, like what is the clinical syndrome and what are the clinical signs. Then only we can correlate the MRI findings with the this particular patient. So
we'll take one last question, sir. What is the specificity of CT scan brain for elderly patient with vertigo?
If a patient comes with vertigo, it's very important that to know that what time you are doing the CT. Like if you are doing the CT scan within the 48 hours of any symptoms, 24 hours is the general thing. The sensitivity of CT scan to pick up infarct, it increases with time, and within first 24 hours, even the CT scan can be normal. Okay, and exactly if I have to tell sensitivity, it is around only 30 20 to 30% sensitive in first 24 hours, and the sensitivity increases with time. But and there are a lot of artifacts which can be seen in patients of like in the posterior circulation. There are artifacts called as beam hardening artifacts, and the brainstem is a smaller area, so we can miss a stroke because the density is not very clear. So it's very important to do MRI brain in patients who are out of window period. If patient is out of window period, go for MRI. If patient is in the window period, it is debatable. We can go for a diffusion scan, urgent diffusion scan, or even CT scan. If CT scan is normal and the clinical picture is like a stroke, we can proceed with thrombolysis. So it depends on what time the patient is presenting after the vertigo. If patient presents after the window period, then we can do MRI.
I hope that answered the question, sir. Actually, this question was posted by Dr. Ben. I'm not sure if.
Thank you very much, Dr. Vishal. Good answer. Thank you very much.
Thank you so much.
So, thank you, sir. We had a really great interactive session for today. I hope the audience had a great take-home messages and good learning experience with this. So we would like to meet again in the next month, first Friday. Is it, sir?
Yes, definitely. Yeah.
Yeah. So we'll be having these Vertigo talks on every month, first Friday. So that is the fixed schedule we'll be having. So thank you very much, sir. For all the audience who have been staying with us since thank you. Have a good night. Thank you, sir.